Today, I want to talk with you about asthma. Asthma is the most common chronic respiratory disease. It's a worldwide problem. In the Western world, it affects 10% of adults and 30% of children. Worldwide, it affects approximately 300 million people, and the mortality rate is equally staggering, accounting for over 250,000 deaths yearly. So the question is, what is asthma? Asthma is an airway disease that has both an inflammatory phase and a constrictive phase. The inflammatory phase involves the mast cells, eosinophils, T lymphocytes, neutrophils, and epithelial cells. Together, these cells and the substances they release cause the airway to have an increased response, which is described as hyperresponsiveness. As a result of this hyperresponsiveness, there is excessive mucus production, which can decrease airflow and, in some cases, totally block airflow. The second phase of asthma is the constrictive phase. In this phase, the airways become very narrow and restrict airflow. The sum total of both phases result in excessive mucus, edema, wall thickening, and narrow airways. Here is a schematic of a normal airway, an asthmatic airway that has mucus secretion and a thickened wall, and the very constrictive airway that has mucus secretion, thickened walls, and narrowing of the lumen. The clinical presentation of asthma. The primary presentation of asthma is wheezing, which is the result of bronchial constriction. Bronchial constriction is usually the acute phase of asthma. This is followed by the inflammatory phase. There is no specific timing between the two phases. Usually, expiratory wheeze is longer than inspiratory wheeze. In addition to wheeze, patients may present with cough, dyspnea, tachypnea, tachycardia, agitation, hypercapnia, hypoxia, accessory muscle use, nasal flaring, chest pain or tightness, and decreased pulmonary function test and decreased forced expiratory volume in 1 second, which is the FEV. Let's talk about taking the history. Getting the history on an asthmatic patient should include the following. Number 1, do you have asthma or do you have a history of asthma? Number 2, how long have you had symptoms before coming to the ER? Number 3, how frequent do you get asthma? Number 4, how frequent do you use medication to control your asthma? Number 5, have you ever been intubated? Number 6, do you have any medical problems like COPD, heart failure, pneumonia, seasonal rhinorrhea, and eczema, especially in children? Whenever a patient comes to the emergency department for asthma treatment, it is always due to acute exacerbation. However, that acute exacerbation may be mild, moderate, or severe. So let's look at each category with which they can present. Mild exacerbation. This would include an end expiratory wheeze on auscultation, dyspnea on exertion, tachycardia, mild agitation. The vital signs are normally within normal range, and there might be intermittent cough, and the patients might report a feeling of chest tightness. In terms of moderate exacerbation, now in addition to the features seen in mild exacerbation, patients with moderate exacerbation may now present with the use of accessory muscles. They may also have shortness of breath during conversation, especially while giving the history, and there will be some tachycardia. In terms of severe exacerbation, these features would include hypoxia, severe agitation, the absence of wheeze, and that's a very important one, the absence of wheeze, nasal flaring, severe accessory muscle use with signs of exhaustion if they're tiring out, hypercapnia, in that the PCO2 would be greater than 42, cyanosis, the patients would most likely try to be upright instead of lying supine or slouching backward, and there may be altered mental status. Any of these or a combination of these would constitute severe exacerbation. Now remember, and it's important, remember, patients are at greater risk for impending respiratory failure if the following are present. Number one, they are non-compliant with their medications. Number two, if they had previous intubation. And number three, if they had a long duration of symptoms before coming to the ER. Now, here is a warning I want you to keep in mind and never to forget. In the pediatric population, and this is specific to the pediatric population, number one, oxygen saturation is a very good predictor of the severity of symptoms on initial presentation. So a child comes in with asthma, make sure you get a reading as to the oxygen saturation on presentation. Number two, there may be paradoxical breathing. Number three, the child may be using accessory muscles and becoming very exhausted. Number four, there may be cyanosis, so pay close attention to the lips. And number five, the respiratory rate, if it's greater than 60 breaths per minute, might be an indication that there is impending danger in these children. Now, what are the risk factors for death from asthma? Let's talk about the asthma history. If these patients who come in for asthma treatment, if they've had previous severe exacerbation, namely intubation or admission to the ICU, that's a very telltale warning. Pay attention to that. Secondly, if they had 2 or more hospitalization for asthma in the past year, or if they have had 3 or more ED visits for asthma in the past year, or hospitalization or ED visits for asthma in the past month, or using more than 2 canisters of short-acting beta agonists per month, and of course, difficulty perceiving asthma symptoms or the severity of exacerbation, which would delay their coming to the emergency room. Now, There's also social history that could contribute to the risk factors for death from asthma. Low socioeconomic status or inner city residents are at risk for higher mortality. And those who use illicit drugs are also at risk for higher mortality. And of course, those who may have mental illness where there's major psychosocial problems. And the third thing we want to talk about is the comorbidities. Persons with comorbidities such as cardiovascular disease or concomitant lung disease or chronic psychiatric disease are equally at risk for death from asthma. Now, in terms of the diagnostic studies, the finding of hypercarbia on blood gas analysis is a strong predictor of impending respiratory failure. And I'll tell you why that is so in a minute. Metabolic acidosis on blood gas is also an indicator of impending arrest. The decision to intubate and mechanically ventilate the asthma patient should not be based on blood gas analysis only. Rather, it should be based on the clinical picture of mental status, respiratory, and air movement by the patient. In other words, if a patient is talking with you and saying, I'm feeling better, I'm breathing better, my chest is not as tight as before, even if the blood gas has terrible numbers, that patient does not need intubation. So do not go by just the number on the blood gas. As a matter of fact, in the acute phase of asthma, these patients will definitely be blowing off CO2. So the end-tidal monitoring in acute asthma exacerbation should demonstrate low carbon dioxide. Now, after they have been in the ER a while and have received treatment, if their CO2 level seem to be normal or high, then that's a bad predictor of impending respiratory failure. So look at the patient in addition to the numbers that you're getting from the blood gas. Now, in addition, a peak flow should always be performed prior to treatment if the patient is able to do it. Remember, peak flow is based on the height, the age, and the sex of the patients. Based on the severity of their presentation, they may not be able to do a peak flow. But the effective management of the asthma patient is based on the clinical picture and not a number. Very important for you to keep that in mind. Now, the question you'd ask is this: are numbers important? Yes, they are important, but they should be interpreted relative to the clinical presentation and the clinical progression of the patient as treatment is being given. Now, let's talk about the treatment. Short-acting beta agonist is the treatment. They're the cornerstone of asthma therapy in the ED. And this is the most common medication that is used for acute asthma exacerbation, and albuterol is the most common one. Racemic albuterol has been the primary short-acting beta agonist. So remember, in the emergency setting, you want to use a short-acting beta agonist. Long-acting beta agonists, such as salmeterol, have no role in the emergency department. Ipratropium bromide works by blocking the cholinergic stimulation of airway smooth muscle. Corticosteroids are the mainstay of therapy in acute asthma exacerbation. They work via two pathways. One, the reduction in airway inflammation, and two, the upregulation of beta receptors. Then magnesium sulfate is thought to work by inhibiting smooth muscle action potential. Then you have epinephrine, could be given IV and or subcutaneous. And IV and subcutaneous epinephrine have been shown to be efficacious for the treatment of asthma. Epinephrine appears to be safe to use in the elderly with very little risk of ventricular dysrhythmias or other significant adverse events. This should not be considered a first-line therapy. And of course, terbutaline should be a part of the treatment regimen if the person cannot tolerate epinephrine. Now, magnesium, here are the doses that I want to mention and go over. Magnesium can be given at 2 grams IV over 20 minutes in adults. For children, it's 25 to 75 milligrams per kg up to 2 grams IV over 20 minutes, and this is the dosage in children. Prednisone may be given at 40 milligrams daily in adults. In children, it's given as 1 to 2 milligrams per kg divided into 2 doses. And this can be given PO with a maximum dose of 60 milligrams per day. And again, this is in children. Epinephrine, you want to give 1 to 1,000. And this is equivalent to 1 milligram per ml. You can give 0.3 to 0.5 milligrams every 20 minutes for a total of 3 doses, and it is given sub-Q, and this is in adults. In children, you can give 0.01 milligram per kg up to 0.3 to 0.5 milligrams every 20 minutes for 3 doses, and again, it is given sub-Q in children. Terbutaline can be given at a dose of 1 milligram per ml, and you can give 0.25 milligrams every minute for 3 doses, and that is in adults. 0.01 milligrams per kg every 20 minutes for 3 doses, and then you may give 2 to 6 hours apart as needed, sub-Q in children. Ipratropium bromide can be given at a dose of 0.5 milligrams per 2.5 ml, and you can give 2.5 ml every 6 hours in adults, and children who are less than 12 can be given 1.2 milligrams every 6 hours, and children who are older than 12 may receive adult dose. You may also give methylprednisolone and dexamethasone. Now, in an outpatient setting, asthma may be classified as, number 1, mild intermittent, which means that there are 2 or fewer attacks per week. Then it may be classified as mild persistent, which means that there are 2 or more attacks weekly, but not daily. And then it may be classified as moderate persistent, which means that you have daily attacks and exacerbations. And lastly, it may be classified as severe persistent, which means that there are frequent exacerbation with physical limitations. Well, in closing, remember the most common cause of wheezing is asthma. However, there are medical conditions that can also cause wheezing, namely CHF, COPD, lung cancer, and cardiomyopathies. It is important to recognize asthma and initiate treatment very early and be aware of signs of respiratory failure. Well, until we meet again, I would like you to save lives and I wish you well. Good night.